going to talk about de-escalation for therapists. By the end of this session, you should be able to describe how attitude and empathy can consciously and unconsciously affect behavior, should be able to name 2 predictors of aggressive behavior, and should be able to list at least 3 effective strategies to prevent aggressive behavior. So when we talk about preventing violence, there are basically 3 things that we can manipulate: the environment, ourselves, and the patient. So a lot of times the environment's a little bit difficult. You were talking about in the kitchen when there are a lot of sharps around. Sometimes you can remove those kind of things out of the environment, sometimes you can't. Sometimes we can't change the environment too much. With the patient, when we're talking about the patient, there's not a whole lot we can do about the patient. The best that we can do is with our behavior, we hope to influence the behavior of the patient. So all of that is to say what we're really going to focus on today is you or me. That's the thing that we can control in a situation to prevent aggression. So I know that some of you are thinking, why are we talking about empathy when we're supposed to be talking about de-escalation? The reason that we're talking about empathy in terms of de-escalation is because there's research that shows that it increases patient satisfaction, it increases adherence to medical recommendations, which is something that all of us want as caregivers. It improves patient outcomes. It increases professional satisfaction. And I don't know about you, but I'll buy into anything that makes me happier at work. And then lastly, really, and most importantly, why we're talking about it today, is that it decreases the potential for aggressive behavior. Whenever I'm having trouble breaking through with a patient and trying to get some rapport with the patient, I'm usually pulling out my iPhone and showing them pictures of my cat. Because it causes that same reaction in them. They're like, oh, he's a crazy cat man. Or they think, oh, I really want to get home to my cat, or I hate cats, or whatever it is. And then you start a conversation about cats, or whatever. And then I really am the crazy cat man. So a little bit about assaultive behavior. Assaultive behavior, probably more than 9 times out of 10, always has a trigger. It has a trigger, it has some sort of precipitant. It's just that, in that 10% of the time where we think there's no precipitant, it's just that we haven't noticed it. Or it's something going on in the person's head that they haven't verbalized. But usually there's something that causes the aggressive behavior. There are probably 2 exceptions to that, 2 diagnoses that I'm thinking of: TBI, and then the other one is sometimes patients with dementia, who also might have some frontal lobe damage. Those patients can be really impulsive, unpredictably so. So let's see. Triggers to assaultive behavior. You did mention paranoia. It can be psychotic symptoms. People with mental illness, as you probably have heard, are no more dangerous than the general population. However, there is a small caveat to that, and that is that patients who have paranoid delusions or who have persecutory delusions, they think that everyone's after them. Those patients can be more violent. Limit setting or saying no can be a trigger for violence. The most dangerous time with a patient who is escalating is when you're touching them. That's why when I used to lead Code Grays, when I would show up, I would move heaven and earth not to have to touch the patient. Because as soon as you touch the patient, the increases of being assaulted go way up. We're talking about preventing violence here, and this is really the key point. You need to be able to recognize the signs of increasing agitation and do something about it. And really the first sign of increasing agitation is anxiety. So what does anxiety look like in your patient? Restless, pacing, pressured speech, fidgeting. All of those things can be signs of anxiety. When you don't do something, there's a chance that that's going to escalate into an out-of-control patient. If you intervene early, sometimes you can take care of the situation by just asking, hey, it seems like you're upset. Did you need something? Offering them something to drink, some water, some Sprite, whatever it is. All of those things are nurturing things that you can do to alleviate somebody's anxiety. If you can catch this early on, you'll never have to use the de-escalation tools that I'm talking about next. Now we're going to get to the nitty-gritty of de-escalation. I've got 7/8 tools for you. The first one is we're going to talk about the environment. What can you do with the environment to make it safer? We already talked about the kitchen with the sharps and all that thing. Sometimes you can remove those items while you're de-escalating. I have a really good trick that when I go for, when I used to go for a code gray, if I was de-escalating you, as I'm talking to you, I'd be saying, yeah, I can see, yeah, that sounds really hard. It seems like we could probably do better next time. Oh, excuse me. And I start taking things away to try to make the environment safer when I'm doing it. You probably already know this, but if somebody is escalating, you want to make sure that you are positioned in the room, that you are between the patient and the door, that you are not up against a wall and pinned into a corner. You want to make sure that you're in a place where you can get out. And as I'm clearing the room and I'm talking to my de-escalating patient, I'm getting myself in the place where I'm in between the patient and the door. So I should probably preface all this by saying this works about 80% of the time. And you're sometimes going to have to use multiple tools. And the next one could be the verbal skills that you're going to use. If the patient is yelling, you use a lower volume. Try to get the patient to come down to your volume. Collaborate as much as possible. Say, what can we do to make this better? Always try to work with the patient. Avoid saying these 3 phrases. You need to, no, and why. Those can be really triggers when you're trying to de-escalate a patient. And they'll tell me, I don't need to do anything that you say. You're not my father. And asking patients why when they're agitated or escalating can seem challenging to a patient. It can seem like you're questioning them. So yeah, don't challenge or threaten patients. It usually doesn't end well. As much as possible, when I'm de-escalating, I try to use neutral words and I try to separate the behavior from the person. So if somebody is cursing at me, I'll say, cursing upsets me. It's really hard for me to help someone when they're cursing. See how different that is from, you can't talk to me like that. Taking off your helmet scares me. I'm afraid you're going to hurt yourself. Being concise, using simple words, using short sentences, and only one concept at a time. And using repetition and saying it over and over. You're scaring me. I'm afraid you're going to hurt yourself. You're scaring me. If a patient continues to escalate and you can leave, that may be a good thing. Sometimes you may just need to leave a situation, and then sometimes that can help somebody calm down. Let's talk a little bit about nonverbal communication. When patients are agitated, there are some studies that show that patients only hear about 7% of your words. The other 93% of the message that's coming through is all through your body language. You really want to make sure that your nonverbals are communicating what you want them to communicate. So having a relaxed posture, a calm facial expression, making sure that your intonation is also calm or calming is really important. And you want to make sure that your body language is congruent with what you're saying. Identifying wants and needs. This is often done in that anxiety phase that we were talking about. Just finding out what the person needs. And sometimes we can meet their needs. Sometimes we can't, but sometimes we can. And sometimes we can use what the patient wants to get what we want done. I would use what they wanted to get what I wanted done. So I would frequently say things like, I think if you take your meds the way that they're prescribed, that you'll probably have a better chance of getting out sooner. I wouldn't make any promises that I couldn't keep. I would say that listening is probably the most important part of de-escalation. I can't tell you how many times I've shown up to a situation where a patient has been out of control, and I've stood in the room closest to the door, and I've just stood there and said, yeah, sounds like we could have done better. I can see why you'd say that. That must be really hard. Yeah. And I just do that over and over again for 20 minutes. And I leave, and the patient's shaking my hand saying, thank you so much, you've done so much for me, thank you. And I leave going, I didn't do anything. All I did was stand there and nod. Just listening is so important to our patients because so many of our patients are disenfranchised. So many of them have no power. Just uninterrupted being present and listening to somebody. Sometimes it's all you need to do to de-escalate somebody. Don't take things personally and try to look at the meaning behind what they're saying because sometimes you have to hunt a little bit for it. Sometimes listening is all that is needed. Next to listening, I would say agreeing with the patient is the other strategy that is probably most helpful for de-escalation. If you ever see me de-escalate a patient, I'm spending the majority of the time saying nothing and listening, and when I am speaking, I'm agreeing with the patient. Now, does that mean that we have to agree with things that we don't think are true? Absolutely not. But you agree the experience of the patient. There's a communication term called fogging, which means you can fog by agreeing with the truth of the statement, agreeing with the principle of what they're saying. And then if anybody says anything that starts off with, well, you'd be pissed off too if, you just agree with the odds, which is, well, a lot of people would feel that way. That's all you have to do. Now, if somebody's delusional, do you agree with their delusion? No, you agree with the experience of the person saying, that must be really frightening. And then if the person challenges you and say, well, you just don't believe me, then I usually just say, you know, that's not my reality. I believe that that's your reality, but that's not what my reality is. And I've never had a patient who has challenged that. The only time I will agree with patients who are delusional is if they have something like a severe TBI or dementia where they're not reorientable. There's no sense in reorienting them because it just can further escalate them. Setting limits. There's a 3-step method that I recommend that sounds like it's a little tricky, but once you do it a few times, it really gets to be second nature. So if somebody is doing something and you want them to stop it, 3 steps. The first step is that you name the behavior and say why it's dangerous, scary, fearful, disruptive, whatever it is. So that's when I said, when I was talking about the helmet, taking off your helmet scares me. I'm afraid you're going to hurt yourself. So I've said what it was and why. The second thing is offer alternatives. If you can put your helmet back on, I can help you do X, whatever it is. You offer an alternative, and then if the person makes the positive decision, then you thank them to reinforce it. Ah, thanks, I'm so glad you put your helmet back on. That was scaring me. Let's go get a coffee. So it's 3 steps. It works, and it works for anything. 3 steps. The last part of the de-escalation strategies is the debriefing. And the reason I bring up the debriefing is because if there's ever a situation where a patient does get out of control, it's really important to debrief so that you can figure out what happened. This is really where you can start to create care plans for people. Hey, I noticed that every time this patient talks to their mom, they flip out. So then you come up with a plan. Okay, what can we do to try to prevent that? How about if when you talk to your mom, you come and get me and I help you? We do some deep breathing exercises together. All right, let's do some personal protection. So the first thing is strikes. If somebody goes to kick you, you're going to block and move. So we're not going to spend any time on strikes. That's generally what we do instinctually. Demetrios, if you grab my arm, just one hand. So one-handed grab. So to get out of a one-handed grab, there are 2 ways to do it. There's one that's really simple, and that's where I just do this. I'm going to use leverage and momentum and an element of surprise to get out of this. The element of surprise is that, what's he going to expect me to do when he grabs my arm? Pull. He's going to expect me to try to pull away. And so I'm going to be pulling him across the room. So what I'm going to do is I'm going to step into him, and I'm going to move my elbow closer to his elbow, and look what happens to his grip. So it's going to change the angle of his grip, and then I can use momentum to get out. I'm still going to use that element of surprise, and then I can use my entire body weight against his little hand. But if I use my whole body to get out of this, he can't hold on to me, right? So that's why you take your other hand, put it on your fist, use your whole body to get out. So that's how you get out of the death grip. All grabs start as a strike. So if you can block and move, then You don't ever have to do the grab. Okay, let's do chokes. Demetrius, I just want you to put your hands on my shoulder. So if he comes to choke me, the first thing is, it starts as a strike. So block and move. If I can't do that because I'm busy talking to Tim about this, you just go straight up like jumping jacks and then turn and get out. It might bruise your neck just a little bit, but you'll still be able to breathe and you'll be able to get out. It also works if I'm not paying attention, somebody come up behind me and is choking me. Same thing, straight up, turn and get out. So what does that do to your grip when I go up like that? It like crushes his hands.